Hello friends, as you all of know that we are participating in the 12-week certificate course in palliative care mm, by integrative approach. Up to now, for the last 11 weeks, we have discussed different aspects of palliative care, symptom management, psychological support, social support, spiritual support, everything we have discussed. But now I am going to talk on a subject which is very crucial. That is the end of life. The patient is going to die. How the family is going to face that situation, pathetic condition, because one of his beloved is now going to depart. And everybody knows that it has to happen, but you have to make the family ready to accept the truth. And that also is skill. As a caregiver, you should know how to break the bad news so that the griefness, the trauma which the patient family members are going to face can be reduced significantly, and they can accept that sorrow, painful situation. With these words, support grieving families and end-of-life pension. In our work, whether as doctor, nurse, psychologist, social worker, or caregiver, we are often present at the most sacred and vulnerable moment in people's lives when death enters the room. This is the meaning. Death enters the room. But what happens after that final breath? The patient has died. The family members are left there in that room. How they are going to be? What happens to the family, the caregivers, to us, the professionals who care their stories? Today's session is about those moments, about navigating the ethical decision at the edge of life, understanding the process of bereavement, शोक है, दुख की घड़ी है उसके समय, and learning how to offer meaningful support to those left behind. So we will explore how principles like autonomy and beneficence play out when choice must be made on behalf of the dying patient. Patient is unconscious. You have to take decision on his behalf, how you will do it. We will learn how grief expresses itself in different ways, sometimes quietly, sometimes fiercely, and how models like Warden's or Cobbler-Rose help us make sense of the marooning process. These are the models, psychological models that they are applicable. This is not just a theoretical topic. Every concept we will cover today relates directly to real people, to families we will meet, and conversation we will have, and to decision we will called upon to make. I invite you to stay present, reflect deeply, and participate actively in today's talk. Let us begin this journey together with empathy and with humanity and with a shared commitment to support those who are aggrieved and those who care. Learning object of the today class is to understand the 4 cardinal ethical principles: autonomy, beneficence, non-maleficence, and justice, and how they apply to end of the life care. This is understand. Differentiate between withholding and withdrawing life support, and recognize legal and ethical considerations involved. Identify models of grief and bereavement like this Cobbler-Rose or the Warden task and their practical application in patient and family support. Recognize the psychological, emotional, and cultural responses to death in patient, in families, and healthcare professionals. Recognize it, the psychological condition, emotional condition. and cultural responses. Apply practical strategy for bereavement support, including the use of narrative, spiritual, and meaning-centered approaches. And discuss the role of advance directives, surrogates decision making, and the doctrines of double effect in clinical setting. Discuss it. And finally, implement self-care strategies to manage vicarious grief and emotional fatigue and caregiver load. So course overview, content summary and practical tips. Introduction to the post-death psychological support, bereavement grief model, and palliative care. So clarify learning objectives. Invite participants to share goals and experience. 4 cardinal ethical principles. Content summary, respect for autonomy, beneficence, and non-maleficence justice. Use case vigantes to have learners identify each principle in action. This is the practical tip. Self-determination, informed consent, and right to know. Role play a patient HCP dialogue to practice obtaining true informed consent. Get the consent of the patient, okay? Autonomy. So cultural dimensions of autonomy. Independent versus enhanced autonomy. East-West difference. So a small group discussion. How would you adapt consent processes in different cultural settings? This is the cultural dimensions of autonomy. Now, surrogate decision making. Hierarchy of surrogates. Use of judicial, guardians, spouse, and adult children. Surrogate decision means the patient is not taking decision, his guardians are taking decision. Judicial guardians, spouse, and adult children. So provide template for documenting surrogate hierarchy and values history. Presumed consent and emergencies. Presumed consent. What do you mean? Default life-saving interventions. Beneficence in absence of explicit consent. If there is no consent, you have to decide the life-saving services. So quick reference flow chart. When to presume consent in emergency. So presumed consent and emergencies. This is important. Beneficence. What do you mean by beneficence? Acting in patient's best interest. Holistic care. Avoiding futile therapies. How you will do it? Checklist. Ask, is this intervention likely to provide net benefit before ordering? This is the decision you have to make. Non-maleficence means first do no harm. Weighing benefits versus risk for every intervention. This is the non-maleficence. Practical. Use risk-benefit matrix during multidisciplinary team meeting. Discuss this issue with multidisciplinary team and evaluate do not harm, benefit versus risk. Justice is very important. Fair allocation of resources regardless of class, creed, and race. Develop resource allocation policy with transparent criteria. There are many government schemes which is going on. You should do justice by arranging those things to your patient. But he should not be deprived of because of a caste and creed. This is important. Withholding, withdrawing treatment. No moral, ethical difference. Focus on patient benefits. No moral or ethical difference. Patient benefit is the first. Practical. Standard operating procedures for documenting decision to withdraw or withhold the life support system. That is it. Futile care. When interventions no longer offer reasonable chance of benefit, why to use it? That decision is very crucial. So create futile checklist for end of the life care discussion. Put your checklist to your team members, to their legal hires, their spouses, their family members, and let them decide whether this intervention is futile or is of some importance. The doctrine of double effect. Acting with primary intent of relief, foreseeing but not intending harm. This is the content. Case study debrief. Morphine use at the end of life and legal coverage. Legal protection, IPC section 81 and 88, very important. Good faith act that may harm are not offenses. Consent criteria. This is the to distribute one-page summary of relevant legal sections for quick reference. You should give to the family members. Advance directive. Arrange the advance directive from the patient or his legal guardian. Legally binding preferences. Appointment of healthcare proxy. If he is unconscious, healthcare proxy, who will take decision. Provide template for advance directive form. Practice completing with learners. Impact on bereavement. Family, caregiver health, physical, emotional, and behavioral reactions. This is the problem. How to address? Use validated screening tools to assess the caregiver strain in the clinics. Kubler-Ross model, DABDA. 5 stages: denial, anger, bargaining, depression, and acceptance. There are 5 stages. Have learners map a real or fictional case onto the 5 stages, which he will observe in his patient. Other theoretical models: traditional phase model, Walter's postmodern model, Park's stage warden's task. To create comparison chart, a small group present pros and cons of each model. Test all the models with the patient and make a comparison. Which one is giving better response? Warden's 4 tasks of marooning: accept reality, experience pain, adjust to environment, and reallocate the deceased. There are 4 things. Role play therapeutic interventions targeting each task. Narrative negotiation in bereavement. Bereavement as ongoing self-narrative. Use of stories, metaphors. Bereavement is the ongoing self-narrative. So guided writing exercises. Ask learners to compose a continuing story of a deceased loved ones. Meaning-centered psychotherapy, MCP overview. Frankel's logotherapy, adapted by Bertibert, addresses hopelessness, burden, meaninglessness. Introduce MCP manual. Have participants review session outline in pairs. MCP group format. 8-week, 1.5 hour session. Dedicate didactic and experimental components. Provide session 1 meaning before diagnosis, handout, and practice facilitation. MCP individual format. This is the MCP group format. This is the MCP individual format. 7 weekly 1 hour session tailored to individuals' spiritual well-being. Walk through case vigent and plan session structure. Psychology of grief and bereavement. Definition: anticipatory, normal, complicated grief, marooning versus grief. Dispense 1-page quick reference definitions sheet for learners. Reaction to loss: physical, emotional, behavioral, attitude. Common reactions, e.g. headache, guilt, social withdrawal. To teach use of standardized reaction checklist during assessment. This is the practical tip for the caregiver which all of you are doing. You should standardize reaction checklist during the assessment regarding headache, guilt, social withdrawal, and common reactions during the death. Content summary. When to give professional help. Indicators: prolonged intense grief, functional impairment, suicidal ideation. Provide referral pathway flowchart for mental health services to your family. Role of palliative care in bereavement support. Proactive outreach, volunteer support, multidisciplinary counseling. To draft a brief protocol for post-death follow-up, call to the families. Coping strategies and self-care for professionals. You yourself is also under stress because the patient for whom you are giving service has died. You have to be careful that you should not get under stress while giving the service. Acknowledge vicarious grief, seek supervision, maintain work-life balance. Group brainstorm, institutional support, peer support is required for you. Cross-cultural consideration. Cross-cultural consideration means rituals, expression, norms, spirituality vary by culture. So cross-cultural consideration is also very important. For that, develop a cultural assessment tool to identify beliefs and rituals and accordingly apply them to the family member. Using social media and technology, memorial pages, closed groups, privacy consideration. So guide on setting up closed bereavement groups, pros and cons discussion is important. Course recap and action planning. Now content summary. Review key frameworks, ethical principles, and support strategies and therapy models which I have discussed so far. Ask each learner to draft a 3-step plan for implementing one practice in their setting. I am giving you a true story. Based on that, you have to write some answer. It was a quiet afternoon in the modest 2-story home on the edge of a city. The curtains were half drawn, letting in a soft, filtered light. On the hospital bed in the living room, the place where the family once gathered for tea and laughter, lay Meera Devi, a 65-year-old mother of 3 children. She was in the hospital and the children are in that room where earlier they were coming to take care of their mother and they were talking to each other. But today's story is different. She had returned home just a week ago after months of hospitalization for metastatic breast cancer. She has a metastatic breast cancer and she has come home from the hospital. The doctors had said there was nothing more curative they could offer to their mother. The disease had spread to bones, liver, and lung. The pain was restlessness, but she had asked to go home. She has come from hospital to home with all these problems because doctor has told nothing will happen. Her husband, Rajendra, a retired government clerk, had aged 10 years in the last 6 months. He barely left her side. Her daughter, the eldest, who lived 2 cities away, had taken leave and come back to help him. The 2 sons, one abroad and one in the same city, rotated shift with their father. A nurse came each day, administering morphine, checklist, vital signs, teaching the family how to clean and turn her gently. Meera, once a lively, meticulous woman who loved cooking and singing bhajans, now barely spoke. She has kept mum. All the Arish Lakshanas have come to her. Yet in her eyes there was clarity. She knew she was dying. She had accepted it. Her only concern, will they be okay after I am gone? The family tried their best to keep her comfortable. Her favorite cotton saris draped around her, her music playing softly, her grandchildren visiting in short, careful moments. There were tears, but mostly silence. An unspoken grief was thick in the air. On the sixth day at home, she did not open her eyes. Her breath slowed. Nurse explained what agonal breathing was, gently prepared the family for what was coming. Rajendra held her hand. Her daughter combed her hair one last time. When Meera Devi passed away, the next morning, the house did not erupt in cries because they were all prepared. They were knowing that her mother is going to die. There was a heavy silence. Rajendra stood motionless. Her husband, Rajendra, stood motionless. The daughter sat by the bedside, stroking her mother's hand. One son called the priest, the other arranged the paperwork. The grandchildren, not fully understanding, played quietly in the next room. In the days that followed, rituals were performed, friends came, food was brought, but the real journey had just begun. The journey of learning to live without the woman who held the family together. This is the very pathetic condition when a loved one passed away. He dies. The family was grateful she died at home, in peace, surrounded by love. But now each of them was carrying a different kind of pain, a silent, fragmented raw. So with this situation, there are some questions I'm putting to you. You can write in the classroom. What could have been done to support this family better before and after her death? How do we recognize silent suffering in grieving families? What role can healthcare worker play in helping a family like this navigating both the loss and the healing? These are the three brainstorming questions I'm putting to you. Try to picturize the true situation of the family. His mother is going, his wife is going, Rajan's wife is going, children's mother is going, but still people are in grief but not crying. They are silently observing that things have happened. Now that vacuum has been created in the family. How to cope up with that? That is the art. And as a palliative caregiver, you have to teach them, their family members, to cope up with that vacuum. With these words, I end my talk. Thank you very much.